2, 3, 1, 2, 3. Okay. So the good news is that this is my last time on stage, so you can be as happy as I am about that. So we're gonna make this a quick session, and we're talking about like data, cloud, crowd, how it's used in the field, all that stuff. So we're gonna make it quick and dirty. I'm going to start off with the crowd and cloud bit and just deconstruct it a little bit. So the crowd is people. It's everybody out there. When they send in information, it can be Twitter, it can be Facebook, it can be SMS messages coming into a system. That's the crowd, right? And then the cloud, we kind of laughed at this at Ushahidi for a while because the cloud, everybody talks about this thing. It's like it's a big new thing, but it's not. It's just servers, right? That's all it is. But now the servers are smarter is what we're saying. So you can be on a little bit dumber device on your hand or one that with not as much power as a full-on computer. And a lot more of the number crunching will go on in the cloud on that server instead. So it just makes it a little bit simpler, a little bit easier to use. It means that not everybody has to have magical devices and doesn't use up as much battery power on your phone. Okay, so that's the crowd in the cloud, and I'm going to pass it over to people who are much more interesting. So Misrak, you're up.
So I'm going to bring in a bit of perspective from the field in terms of, what are the issues we encounter when we are supporting health centers. For example, in IntraHealth in Ethiopia, we're supporting about 500 health centers in maternal and child health and HIV. So in terms of the data, data is basically our day-to-day life because we needed to report to our donors and also use the content to make, wise decisions. One of the challenges that we encounter is some of the requirements that we have from the donors in terms of the data is not accessible at the health center. So we have to create these parallel systems to collect some of this information and set up a completely parallel system because the government system does not have these type of issues. And at the end, it becomes a bit cumbersome for the government because you have all these agencies like us who have their own sets of data collection tools, and the health workers don't really have the time to collect this information. So some of these organizations even hire the data officers to collect this information for donors. So sometimes, you question in terms of, what's the sustainability of this all. So in Ethiopia, what the government decided when when it looked at all these parallel systems to create, a one plan, one budget, one reporting methodology. So you could no longer try to gather data from the health centers. Again, setting up a health management information system can't happen overnight. And again, you have to think of these health centers, they're in rural areas, there's no electricity, no water, yet, these, health information systems require to have computer, connectivity, staff that has the capacity to do the work, software, etc. So again, it delays a lot of the reporting and, donors had to have some kind of negotiation with the government to have at least some kind of parallel system while, the health management information system from the government site is established. We do collect this data. It's really useful for us. For example, at the organizational level, that enables us to prioritize, what level of technical assistance do we need to provide, what kind of training do we need to provide. For example, if we have, infants that are not being tested, then it's a red flag in terms of, maybe there's, no supplies or the laboratory machines are not working. So we use data in that manner, even though it's at the basic, elementary level, at least, we use it for making these type of decisions. And for the health centers, again, it's very useful because we have, instituted simple things like what we call the tracking chart. So that's where the health workers are able to see, the HIV positive pregnant women have taken their ARVs, their drugs, if their children have been tested, and then if their children are on drugs. So at least if that enables them to see if there are women missing, and then if they're missing, then they go out in outreach and look and try to track back the women to come and get the drug. So at least we have simple tools, but they enable us to at least make the right decision. So that's from the field.
Thanks. And I think the exciting thing that's happening with data, especially when we're talking about international development, farming, health, is that we now have cell phones that really enables us to kind of gather data ubiquitously. So when we're talking about data, that means that The coverage is better. We have better coverage over the data. It's more timely. And we hope that the goal of that is it's more actionable, right? That's kind of the promise of the data. But by working in quite a few mobile health projects, I've learned kind of two things. One is that just because you have data, it doesn't mean that anybody's actually going to look at it or use it. So that's the first kind of step. You have to build that culture of understanding why data is valuable. You also have to realize that there's already a lot of kind of data systems in place, and you have to make sure you don't short circuit those. And it's really ultimately, the value of the data really is based on the context of the user. And I just want to kind of show you my 2-second fail-fare example. So I'm working on right now building an app for nurse midwives in India with the National Rural Health Mission. And anybody in the space knows it's one of the, like nurse midwives are like the doctors in most countries. They have a tremendous amount of functions. So we spent an enormous amount of time capturing all the data elements for nurse midwives, all the different forms, so how do you deal with out-of-area patients, blah, blah, blah. So we came up with this design, which we thought was really awesome and the best thing out there ever in mHealth. But you can see that it basically, if you just go back one slide, all it showed was just the names of the mothers, but then if you click in, you have like their whole full medical history, their birth plan, all these, go one slide forward. Like all the details that you need and that they would need are here, all right? But we had a big mistake in that the way we built the app is you can only see the details of one patient at a time, right? So in a way, if you just kind of click through these, please. It's like an analogy is trying to see the color of a tree when you can only see one color of a leaf at a time, right? And we were kind of missing an obvious fact that they had paper systems in place. This is a grid. They would study this. This provided way more information than we were providing in our app, right? We were actually hurting their work by proposing that. And guess what? You think they used it? No. So we're actually extending our, it's hard to write milestones 2 years before the project starts, but we're in negotiations with our donor because we failed. And we have to kind of come up with a better system. So we basically looked to the inspiration of what they're already using to develop an interface like this, a smart registry interface, that allows them to see all their patients at once, switch between care modes. If you have 50 children in front of you, want to do immunization, what can you do on paper? You can just do a little checkbox, right? So if you're making an app on the phone that's more complicated than tapping on a thing once, then it's not going to fly. So I just wanted to kind of provide that it's really about how you provide the information, how it's meant to be consumed by the person. That's really matters. Like big data, yeah, it's sexy. I don't really even know what that means yet because I haven't seen it. But it's about the data for the end user that really matters. So as you do your work, focus on that initially.
Great. It's a great segue because I feel like every time there's a big data panel at a conference, we have to define big data on that panel. And I'm not going to try to do that. But to me, when I hear big data, the word big means something, and it means too big, and probably too big for human beings is really what that means to me. So it's a data set that's too big for a human to look at and make sense of, and learn things about that catchment area from. And we are not there with global health. Right now we have messy data, we have incomplete data. I don't think we have big data, but we can plan ahead for when we will. And that's partially the technologist's job, focused on interoperability and things like that. So that's the first thing I'd say.
Hey, Josh, when you say that, do you mean that that data is not being, I'm not from the health worker side, so I have no idea about the health data, right? Are you saying it's not being collected and digitized at all?
So status quo in global health is that a community health worker collects paper forms in a notebook for up to 6 months, 6 to 12 months, and then walks 30 miles to hand deliver that to someone who will key that into an Excel sheet. And it may be maybe 25% of those facilities, that data will get to the ministry level.
So is there any country that we can think of in Africa, Asia, South America, wherever that has a lot of that stuff keyed in? Is there even one? I'm really just
there's
ignorant
a ton
of
of progress being made,
so.
and it'll be a different. We'll make a different comment in 5 years for sure.
Okay.
If we do our job in the room, but.
So there really is no big data in health, and so what Matt's saying is correct.
So Walmart has big data challenges and opportunities, and Target does, but I don't think we do just yet.
There's no actionable big data. There's a lot of big studies that tell us ways to change our. Sorry. There's a lot of big studies, like DHAS studies, that tell us how to change policy,
Right.
but it's not. RCTs are huge data, but it's just it's not actionable.
Okay. Okay.
And we're not doing
For the healthcare workers.
we're not doing social network analysis right now, and we will in 5 years.
Okay.
For example.
Sorry for interrupting. I
No,
just
thank
curious.
you. The second is I really want to put out a word of caution. I heard a phrase that data is the new oil, and it terrifies me because so much of our history, the world's history in sub-Saharan Africa is extractive. And so every time I hear someone talk about big data as a business model, I want to try to convince them otherwise. And I think that that's a resource we need to get right. And it's an extra tool for decision making, and it is not a revenue stream. So I just wanted to put that out there as a thought. And then the last thing, really quickly, is I want to. I have an idea that I would love to partner with this whole room, people like you and Matt and Misrak. We have an opportunity. We have community health workers who are going household to household and reaching 2 billion people or more right now. And because of these new technologies, just pretty much as a byproduct of us using mobile technology instead of paper, we're going to have information about these activities and the services being provided to the minute as they're happening. And that's going to be unprecedented. But there's an opportunity, I think. There's a tool called the Lives Saved tool that was funded by the Gates Foundation and built out by researchers at Johns Hopkins. And what it does is they have updated global health data sets, the DHIS studies, the DHS data, World Bank data, and then they have effectiveness scores for all the interventions that we know save lives. This many antenatal care visits leads to this probability of a woman surviving childbirth. And so it's a massive mathematical model that a couple of donors use to evaluate new proposals. And it's time to open it up. And I know Gates wants to do it. I know the researchers at Johns Hopkins do. And so it's basically a match made in heaven that I think in 5 years, we'll be able to send this real-time activity data to this impact processing center. And not only will we be able to tell a Ministry of Health and a Gates Foundation how many lives are being saved and how many DALIs are averted, but you'll be able to tell that health worker that last campaign that they worked on last week means that this many under 5 deaths will be averted in the next 5 years in your community. So I think we can do it, and I think this is the room to make that happen. So I wanted to put that out there.
Cool. So we have like 2 minutes left to finish up. I have a question for actually the three of you because you're in this field. It seems like there's information, there's projects, there's pilots going out there, pilotitis kind of stuff that Matt was talking about. But there's information and stuff out there. Is it being analyzed at the right way? Is it being analyzed for funders only? Really? Is that why we're analyzing it and how we're analyzing it, or is it being really analyzed for the end user or for the person who's needing their health to become better?
So it depends on, where we are in the stage of, programming, because at the end of the day, all this information collected the first user should be the health professionals or the health workers at the health centers. At this point, most of the organizations are, rushed and putting these in reports, and then it's like a cycle where you can't really get out and you collect information. It's all about reporting, but it's our responsibility to somewhat step out and then figure out, okay, even if it's small, how do we use this information to improve, the work of the health workers themselves? So as I was saying earlier, if there are patients that are missing, okay, good, let's use that information and see where are they, where are those women located, and let's try to get them back at the health center. So there's a movement towards that, but it's not used at 100% of what we could do.
Yeah, just to kind of go along, I feel like the quality of the data is always going to be maybe in the very beginning of a project there's a lot of trainings going on, a lot of oversight, but ultimately the quality of the data is going to be based on how much the person collecting it values it. Is it providing value back to them for their daily job? And if you create that, that's the only way these systems are going to work. So you have to be, kind of my point earlier, it has to be focused on the user. And all the side effects, the derivatives of that, should be used by for reporting at the government level. But especially if you're using it as a job aid, a way to make their lives better, to be more effective, it has to be the primary focus.
So I guess what I'm trying to get at too, and before you go, Josh, is like, are the incentives aligned, right? If the funder, if you're receiving funding from a funder who's saying mandating this kind of thing, and then you've got guys on the ground who want this other thing, or it's, like, how does that work so people are getting what's actually needed, and you're analyzing the information and making sense of it in the way that's good for them, not good for the funder? As we have this problem in other fields, right? It's not just health, I'm guessing.
The short answer is that that the customer being different than the user in global health is a big challenge, but can be solved very quickly if you help the customer understand that what is best for them is what's best for the end user. So that's how you solve that.
Okay, and are the funders listening?
They are,
okay.
Across the board,
right.
Absolutely.
So give him more money, he just said. All right, so I think that's it for us up here, unless anybody has any last statement. Okay, so if you have any questions on big data or what it isn't, as well as crowd, cloud, and other stuff, I can't remember what the other 5 things were, but you can talk to us later. Thanks a lot.